Hello, good afternoon. From Madrid, from La Paz University Hospital. It's a pleasure for us to be again here another Wednesday for the medicine program. And we have the first live case of today. Beside me, I'm going to present all the team. Beside me is Dr. Guillermo Galeote. Pilar is the nurse scrubbing. It's also Carmen. And Monica outside. We have the support of the anesthesiology team as always. Dr. De Campo, Dr. Freitas, and also the cardiac imaging team with Dr. Labuena and Dr. Saldaña. We are going to present the case firstly. Clara Hugueto, our resident, is going to present some slides. Clara?
Yeah. Hello everyone, thank you Alfonso. I am going to present the first case. We have a 58-year-old male, former smoker. He has a medical history of atrial fibrillation and is on treatment with antivitamin K. He was hospitalized in February of this year because of acute heart failure. A transthoracic echocardiogram was done in which he was diagnosed of severe mitral stenosis with mild regurgitation and a normal ejection fraction. The mean gradient of the mitral valvuloplasty is 12 millimeters of mercury, and the area estimated by 3D planimetry is 0.8 square centimeters. The electrocardiogram shows atrial fibrillation, and the blood test is normal. Here we can see the images of a previous transesophageal study. In the first one, we can see that the valve is not calcified and the leaflets are thin and appropriate to do the procedure. The Wilkins score is 8, and in the second one, we can see the severity of the stenosis with Doppler color, and in the third one, we can see the small area of the valve in 3D planimetry. So we are going to do a percutaneous balloon valvuloplasty guided by transesophageal echocardiogram. So Dr. Jurado and Dr. Galeote are going to do the procedure. I think they are there. Sí.
Okay, so that's the case. As Clara said, we have a severe mitral stenosis, and now Silvia is going to explain us the current situation of the echo.
Yeah, hi, welcome everyone. I'm Silvia Valbuena, I'm the echocardiograpist. So here I think you can see my echo, yeah? Mm-hmm. Okay, so first thing you have to do is, of course, before we come to the cath lab, we have to appropriately select the case. So that's the, I would say, the main role of the echo, if it's possible, of the transesophageal echo. So first thing you need to check is that it's a rheumatic disease with commissural fusion. I mean, the objective of the valvuloplasty is to open the commissures. So if you don't have a commissural fusion, you're not going to open the commissures and you're going to break the valve. Okay, so you can see here an en-face view of the mitral valve from the left atrium. This is known as the surgical view, and you can see this fish mouth opening of the mitral valve, and you can see that both commissures are fused. So the morphology of the valve is fine, the mobility is a bit restricted, it doesn't have a lot of calcium. You can see here, this ball here, is a bit of calcium in the anterior leaflet, which, well, the best would be no calcium, but okay, it's acceptable. It's not a lot of calcium. And yeah, you can see also here in the 2D view that the subvalvular involvement is not, I would give it a 1 in the Wilkins score. I mean, it doesn't have a lot of subvalvular involvement, which is great because percutaneous valvuloplasty and subvalvular involvement don't go very well together. Okay, so first thing, when we before the procedure, we have measured the gradients, the basal gradients. We have done this before. I will show you here. So here you can do it here in the echo machine with the NPR reconstructions. You go, you place the planes in the minimal area during diastole, and then we can measure it here. You can wait. I will show it. This here would be the minimal mitral valve area, which you can see here in fast view. It corresponds with the morphology of the valve, okay? And the area would be 0.85 millimeters, okay? So it's a severe mitral stenosis. And we also have to check before starting. We have checked that before today, but it's better to double check that there is no significant mitral regurgitation. You can see it here, that regurgitation is mild, okay? And of course, you have to rule out any thrombus in the left atrial appendage. You can see it here. We can use the biplane mode to have a better look at the appendage. And you can see here that there is absolutely no suspicion of a thrombus. Okay? So we would be ready to start whenever you are, okay, Alfonso and Guillermo.
Okay, thank you, Silvia. We have another comment of the echo. You see some funny smoke in the left atrium. We have now administered a slight dose of heparin before the transseptal puncture. Just we do it in every case. And now I'm going to actualize the setup. We have an 6 French radial sheath just to have a pigtail in the aorta. And we did echo-guided puncture of the femoral vein, just to use one proglide. We use it when we go with sheaths over 14 for the final closure. We are going to start the transseptal puncture. So we have here up in the superior vena cava the sheath for the puncture, and I'm going to advance the broken back needle. And Guillermo probably can explain us some parts of the procedure.
Yes, the sheath is a special. Is XL1. The curve is a little more curved than the regular sheath, and the needle is BRKK extra small. These are with a special needle. Okay.
Just a second, Guillermo. I'm going to advance the needle. If you can see my hands on the table, we advance the proximal part of the axis with the stylet, and then we retrieve it to advance with continuous flashing. Sorry. Continue. No, me tienes que dar de este.
Yes.
Continúa.
The previous transseptal puncture, we have 3,000 units of heparin, but the patient, the weight patient is more than 100 kilos, but it's a little heparin with the objective to avoid thrombus in the needle catheter.
So
okay.
we're going to start the transseptal puncture. As you can see, we have the echo guidance. We have the needle pointing in a imaginary clock to 4 or 5 hours, and I'm going to retrieve all the system until Silvia confirms me I am in the exact point of the puncture. We're going to try to puncture posteriorly and the upper portion of the fossa.
Mid portion in this case could be a good option. More or less 3.5 height from the mitral valve plane.
Yeah, maybe a little bit, because we want to avoid the thick. Yeah.
No.
There.
But I'm not doing tenting.
Todavía, no? Tenting, we need to see the tenting.
Yeah, the orientation is not great. I would say, no, you're too close to the aorta.
No. Okay, a ver ahí.
I can see some tenting.
No, pero no hay un tenting.
In the plane of the right.
I would say a bit superior. 1 second. No, too close to the aorta.
I'm trying
I
to.
would say a bit posterior.
I'm going to
Can we see the short ASICs?
You can see the aorta here, Guillermo, here on the right image.
A little more posterior,
yeah,
probably.
Yeah, that's
no, it's not too much. No.
Look the image.
Okay.
What do you think, Silvia?
Yeah, it's maybe a bit posterior, but you have plenty of room.
I can go a little bit anterior.
Yes,
yeah,
but it's difficult to move it inside the patient.
Nice.
We prefer to be sure that it is a good position, because if not, crossing the mitral valve would be harder. So, do you agree with this position or not?
A little more anterior is possible. Is it possible? If not, I think it's enough. It's enough good.
0.5 millimeters or 0.25 or
no, 2 millimeters. Okay, no, yo creo que está bien, ¿no?
It's a safe position.
Agree?
Okay.
Yeah.
I'm going.
Mantén un poquito la proyección anterior.
Okay, you've crossed to the left atrium.
So I retrieve the needle, I advance the introducer and the sheath together. I have crossed with the sheath. Okay. So
Now,
we complete the heparin, please.
Okay. ¿Le podemos poner la heparina completa, por favor?
And I'm going to retrieve the needle and the dilator.
Okay. Déjame ponerla con agua.
So you can see with the echo guidance, transseptal puncture is another business.
Yeah, the key to a safe transseptal puncture is it's very easy with the biplane mode. Sorry, and you can see the bicaval view here on the left, and then we do with the X-plane mode with the perpendicular image. We see the posterior part, the wall of the atrium and the aorta, which is something you definitely want to avoid.
0.35.
Sí.
Right oblique.
We're going to try to take a mean gradient. What the echo study is perfect, but we are from the old school yet.
Nobody's perfect, Guillermo.
Casi, ¿no? A ver. Sometimes it's easy to cross the aortic valve, but sometimes
just the angle.
Well, my mean gradient is 8, although it's atrial fibrillation. Okay. We should do an average of several.
There are some questions on the chat.
Some questions of the audience?
On the chat, yeah. The first one is if there is any commissural calcium, any other negative predictors?
It's for you, the question, Silvia.
Yeah.
If there is, in this case, commissural calcium, yes, there's one calcium nodule in the, 1 second, I will show again, close to the medial commissural commissure. Sorry.
¿Está ahí? ¿Allí?
Yeah. So, of course, calcium, the best calcium is no calcium. I mean, but the medial commissure, you can see it here. That is thickened.
Sí, ponlos los dos a cero. Can we do the zero,
here,
please?
This
zero?
is the calcium. So the lateral commissure is free. So, well, the best is no calcium, but it's acceptable, I think. Here you can see it here. There.
They also ask about the heparin dose after the transseptal puncture.
Okay, it depends of the weight of the patient, but habitually we use 1,000, 2,000. In this case, it's more than 100 kilos, and we use 3,000. But it's is only a little heparin because sometimes we have to.
We don't have the zero.
We have problems.
No está el cero. Ahora.
Several years ago, because sometimes it's possible to have thrombus in the needle of the transseptal, no? And with the ETE, to have a problem with the transseptal puncture is not is rare, no?
Can we store this image and measure an ingredient? Although we believe more in Silvia, in general. In general.
That's what you say now.
¿Cuál es tu gradiente?
8.
¿Y ahí cómo sale?
8, exactly the same. Okay.
Is the same gradient by ET and hemodynamic, no?
I'm going
8 gradient.
If you agree, I'm going to retrieve the pigtail because it's doing some extra bits and we have the gradient.
Yes.
I'm going to retrieve to the aorta the pigtail. And the next step, we can switch on the light, please. I don't know if it's better for the screen or not. We are going to prepare the Innovo balloon.
Okay. See. First, we perch with the bent tube. Push, push,
Cerra la puerta,
push,
por favor. Cerra la puerta
push,
fuera.
until we can see the flush is a third of contrast and no, yes, no more. Push without problem. Strong. Okay, it's enough. Okay, it's enough. Now we have to take off the air of the Innovo balloon.
We're going to put it in the... Vale. While Pilar is retrieving the air, we can explain all the things that the Innovo balloon has.
Okay. Yeah, go ahead.
Probably, okay. So we have this pigtail wire that we're going to advance firstly through the Mullins sheath to the left atrium. And over this wire, we are going to advance this dilator. It's a 14 French dilator to dilate not only the septum, but also the axis, the femoral axis.
Yes, the subcutaneous tissue, yes.
Okay. And we have also two special features of this balloon. That is the, what is the...
The stress tube.
The stress tube. The stress tube is this one that is going to be inserted inside the balloon just to stretch it and cross the septum. And after that, we will use this stylet that has this special, I don't know if the camera can see it, this special shape, just to direct the Innovo balloon to the left ventricle.
It's for to drive the balloon.
Sometimes it's not easy to cross, but that's all. And now we are going to measure the balloon.
Yes.
We are going to use a 28 balloon. We have 3 sizes, 24, 26, and 28. The measure is more or less calculated with the height of the patient. He's, if I remember well, 178 or 76 centimeters.
Yes, because the bath has a little calcium, but I think it's less aggressive, probably 2 or 3 millimeters less than the...
Yeah, but we have to, with this 170 something, we have to divide by 10 and then assume 10 more. So 170, 17 divided by 10,
26.
Then plus 10 is 27 more or less. So we are using a 28 millimeters balloon, then to be, as Guillermo said, to be conservative, inflating.
First time is not, first time no?
Inflating to 25. To measure it, as Isabella and Guillermo said, we are going to measure at the second inflation because it's more accurate.
Okay. That is the good time. Okay.
And we're going to measure in the waist. That is 26, sorry.
perfect then.
As you have seen, the balloon has 3 steps of inflation. Firstly, the distal portion of the balloon is inflated. After that, the proximal part, and then the waist.
Well, okay. We are going to stretch the balloon now. Please, Alfonso, can you hold? Thank you.
This is another
This is
tricky
the
part.
silver against gold part.
Metal with metal, silver with gold.
Never push the gold part against the lock key without silver part. Always together, okay? Now, a ver si vemos that.
You have
unlock.
The balloon has
Unlock here. Lock. A ver si. No, sí. It's okay. Sí. Now,
okay.
Perfect.
So as you have seen, the balloon has been stretched. So metal, plastic is the thing.
Yeah. Okay.
Let's go.
Okay.
So
now, picture wire.
There are 2 more questions on the chat. The first one is, which technique do you prefer to guide the transseptal catheterization, the echocardiogram, transesophageal echocardiogram, or the intracardiac echocardiogram?
Okay.
Well, that probably depends on the experience of each center.
Okay.
Perfectly with intracardiac.
We don't have experience with intracardiac echo, sincerely. We have anesthetic every day, more or less. And well, it's possible. I know that other teams use the intracardiac echo, but we are very happy with this technique. It's safe. The information is very good. Our colleagues from Image are very good.
And the last question in the chat is about the predictors for stenosis in this patient.
Predictors for stenosis.
Restenosis.
Okay.
Well, a suboptimal result, I guess.
Yes.
I mean, depending on the result that you get after the dilation, sometimes you get a nice, you open totally the commissures, and then you have a nice big area, and the mean gradient falls significantly. But sometimes you can't inflate several times or dilate as much as you'd like, because there is a risk for mitral regurg. So,
thank you very much.
I fully agree with Silvia. If we don't follow a good area, probably the restenosis will be soon.
So we, as you can see in the angio, we have advanced the pigtail wire towards the ceiling of the left atrium. We're going to retrieve the transseptal sheath, and we're going to advance through this wire. There is a 0.25 inches wire, the dilator, the 14 French dilator.
Yeah.
It's an important part of the procedure because the Inoue balloon goes without any sheath. So it's important to cross the skin.
Yes. It's very important to open with the mosquito the skin and subcutaneous, because the balloon is going up without sheath. Primero abajo, tira un poquito abajo ahí. Okay, ahora esto aquí. Entrar y salir, porque si no.
Okay, you have to dilate till the pigtail portion of the wire, not more. I'm going to be back 1 or 2 times.
Yes, we will recommend it to pass the septum 2 or 3 times.
Okay, I think it's enough.
Yeah.
Okay.
So now we are retrieving the dilator, and we are going to introduce the balloon that Guillermo and Pilar prepared before.
It's very important to place the wire up of the left
atrium.
Yes. that in this case is perfect. Okay.
And sometimes you perform a perfect transseptal puncture in the upper portion, posterior, and then the coaxiality towards the mitral valve is not always the best. So let's see in this case. Pilla la guía.
Yeah.
¿Tienes?
Yeah. Okay, no?
Okay. The balloon has crossed the skin with
That is
a little bit struggling.
Yes. It's a compromise step. One moment.
Lo giro yo.
Sí.
Pilla la guía.
Yes. We need to cross the septum first. Turn. Clockwise and okay.
You have crossed now.
A little more, please. Okay, that. Now we retrieve the silver, the stretch tube, a liter, 2.5 centimeters.
Metal with metal, the first thing. And then.
Okay, now the gold part.
Excuse me, you're in the left atrial appendage.
With a wire.
Métete un poquito. We can inflate the balloon a little. ¿Estamos en la aurícula izquierda? Sí, ¿no?
Sí,
¿Puedes pasar un poquito más el balón? Pasar un poquito.
No, Silvia, porque estamos en la orejuela.
Sí, no, ya estáis fuera.
No, era solamente una parte.
Yeah.
A ver.
We're going to inflate a little bit the distal part of the balloon, just to be sure that we are not going outside the septum.
Okay. Now we can retrieve the pigtail wire.
Okay.
¿Es okay? A ver.
Una burbuja.
Estamos en el lado izquierdo, ¿verdad? Que no estamos.
Sí, ya.
Okay, we're retrieving the wire.
And the tube, the silver is
the stretcher.
The stretcher.
Okay.
And now we need to use the estilet to drive the balloon from left atrium to left ventricle.
Cuidado que se engancha con la guía.
Okay. A ver.
Puedes quitar la guía de ahí.
Me tiro de la guía, ya está. Okay, we move
to the right of the quad.
Yes, 30 degrees. Podéis bajarnos la intensidad de la luz.
Plano para cruzar ahí.
¿Qué necesito? What do you need?
The plane you prefer to cross the left ventricle.
Okay. 1 second.
Are you sure we are in the left atrium?
A ver, seguro, ¿no? Ya nos hemos salido.
Yeah. You are.
Yes.
You're as usual in an anterior position.
Yes, that's. We need to move.
So like repeat it, in which position?
In the anterior position.
Okay.
You can see here on top of the aorta.
Mete el estilete quizá, ¿no?
Okay, fine.
Mete el estilete para que.
Entero, metido bien.
¿Entero? Vale. No sé si tienes mucha.
Ok, mi anterior un poco.
Igual te tengo que sacar un poco
de
aire.
We have another question on the chat.
Cuidado que voy a sacar un poquito de aire.
Vale.
Yeah. And it is, how do you choose the ideal valvuloplasty balloon size?
It depends of the tall of the patient. In this case,
the height.
The equation is ¿cuánto mide? ¿Cuánto mide el paciente?
1,78. Te lo explica yo antes.
Okay. The patient is 1.78 m.
You're impacting the posterior leaflet.
I'm there, but it's not crossing.
Pasa lo mismo que antes. ¿Cómo se? Divide between 10 and after plus 10. Then more or less is 27.8.
Yeah, you crossed.
Okay.
You're in the left ventricle now.
It's entering and retrieving.
Okay,
No lo sé.
¿Para qué? Bueno.
Okay.
No me he metido aire.
I'm not sure
Bueno.
the balloon is going to keep inside the left ventricle.
Puedes bajarlo un...
Ahí. Okay. We are inflating the distal portion. I'm going to retrieve a little bit. And when we are in the valve, Silvia, please tell me.
A little more back, no?
Yeah, I would say you're in the right position.
Okay, inflate. And finally, the mid portion. Okay. And back. Back.
Okay.
Okay, now we need to check. First thing is to check for MR. Okay. Which hasn't changed. Okay.
Yes.
There's a mild MR, but...
Sí. Now we are going to check the valve because we need to go to the left atrium. Mete el auricular. Sí. Mete el auricular, tira un poquito así. Okay.
I'm going to wait 1 second for the bubbles to leave. Okay.
The most important thing is open the commissures.
Yeah, I would say mitral regurg has increased mildly, but not a lot. I think it would allow another inflation if it's necessary. Let me just check the area.
Okay, that's...
Well, the lateral commissure looks better.
With more heparin?
1 second, I'm going to measure the area. So you can do it here in the echo machine.
So while Silvia is measuring the area and the gradient and the MR, the anesthesiology team is checking the ACT and the patient is a little bit low. So we're going to reinforce the heparinization.
A ver. Sorry. Okay. So first we need to choose the right frame. You can see here on the bottom right that we have a volumetric reconstruction, so we can check there when the valve opens the most. I would say maybe here. Yeah, here. Okay. And now we need to place the MPR planes here. Here. Let's do it a bit bigger. Sorry. This takes a bit of time. Not a lot.
Don't worry
just
at all.
A bit.
We have additional 25 minutes live.
Okay, great. So, okay.
Is there another question, Clara, from the audience?
No. For the moment,
looks good to me.
There are new questions.
No questions. Okay.
No questions. No.
1.5. I mean, it has improved, but I think it would allow another inflation.
What do you think?
Okay, I think it's a big man.
Yeah, 1.5 is not a lot for him.
Yes, it's possible to gain a little more area.
I mean,
be better.
MR is mild.
Yeah, MR is still mild.
Okay, let's go.
I think.
I mean, there's a lot of acceleration there.
The balloon was 28, no?
The balloon is 28, inflated at 25, 26, more or less, 26.
26. I think 1 millimeter more.
And also probably we can inflate with the same CCs, or you achieve the end of the
Or at the end, 28. At the end is 28.
No, 28, but almost, because
probably
without...
probably we need more contrast con la otra jeringa. Bueno, arréglalo sin problema, que hay tiempo. Arréglalo.
So just one comment, when we go over the decision to do another inflation, we have to resist the temptation of measuring the gradients, because, you know, it's the gradients we cannot reliably assess them after valvuloplasty, because the compliance of the auricular ventricular compliance changed acutely, and you cannot rely on the measurements of the mean gradient for this.
This is a very good point, because in the past we relied in the gradients, in the invasive gradients, and it was a little bit discouraging for us.
Yeah.
And now we have the guidance, so with this planimetry of the valve, we know we have almost double the initial area that the patient has. And now Pilar is preparing again the balloon with a little bit more contrast and saline.
Yeah. But the best is to do a 3D echoplanimetry.
The best thing.
That's the best method.
We have a new question in the chat, and it is, how do you handle subvalvular entrapment of the balloon?
Of the balloon? By preventing it, I guess. The best way is to prevent it.
No, when you enter into the left ventricle and you inflate the distal part of the balloon and you feel some resistance, it's better to deflate and retrieve again and look for another position. If you inflate the balloon completely, you're going to break a corda of something, and you will have a complication for sure. ¿Estamos o no? Pilar, is ready? Okay.
When you have the ETE, it's very important to be in the center of the valve, no inside the ventricle.
Let's see if we can cross again. Silvia, can you?
Sí, sorry.
Come on. Un poquito por arriba, ahí, por ahí, a ver. Ahí un poquito así. Por allí podría ser, pero eso es. Sometimes it's difficult to close another one because the balloon is...
You're nearly there. The position is good, but
yes,
you need to enter.
Yeah, it's facing a nodule. I'm moving anteriorly the...
You're a bit posterior.
Yeah, I'm moving anteriorly the balloon and playing with the stylet, but sometimes it's more difficult. And it's a good part of being too staff here, because in a minute I am bored of this, Guillermo will cross.
No puedo inflar un poquito y cerrarlo. Eso no puedo hacer.
No puedes inflar. ¿Para qué quieres cerrarlo?
Es que si no lo cierro no se me queda el inflado.
Para que no se... Sí,
¿Me explico lo que te quiero decir? Porque es que tiene muy poquito...
From the upper portion of the... like before. No ayudáis nada, tío.
Sometimes it's possible to make a look in the left. Okay.
You're in now.
Fantastic. Okay.
Inflate a little bit. Okay, I'm going to retrieve.
Yes, back to the...
It's free, just for the previous question. I'm retrieving it. I'm retrieving it a little bit more.
Okay.
We are in the valve?
Next to the valve, yeah.
Okay.
Yeah.
Let's inflate it. Okay. And down. And I'm going to retrieve the balloon to the atrium. Okay. MR is not...
Okay, 1 second.
Okay.
Yeah, good. MR is still mild.
Should be enough, eh?
Yeah. Yeah.
While Silvia is measuring the result, just a comment.
Podemos medir el gradiente nosotros.
Yeah, MR, it has several jets, but it's very protosystolic.
I was saying that this procedure is very uncommon in our country because this rheumatic mitral stenosis is quite rare. But you have to be trained doing this because the patients are there. And for example, today we have done another similar procedure before this live case.
Sorry to interrupt. You can see here in the 3D view that the lateral commissure is open now, and the mobility mainly of the anterior leaflet has greatly improved. Okay, you can see it there. Can you? So I'm going to measure the area again.
No, the image is quite better.
No, the 3D image looks much better.
Which is the basal area?
0.8, more or less.
0.8.
We are going to enter into the ventricle just because we have an old school friend here that believes in ingredients. If we are not able, after Silvia measure everything.
My mentor checked the result with the cardiac auscultation.
A real cardiologist, not us, with all these gadgets.
So just orientate the planes as we did before towards the smallest area.
Okay.
And here, I'm not right.
¿Cuál era cuál?
Para que no se enganche en el...
Ok, este es ese.
Vale, pero tenemos esto...
Quítalo. Saca el estilete. A ver. Vale. Y ahora con la otra. Esta es.
It's big. I mean.
Okay. If anyone can measure the gradient outside, ¿podéis medir el gradiente?
Todavía no ha caído a la diastólica exactamente, pero bueno.
2.3.
2.3.
Wow. Yeah.
I think
very
gradients
very good result.
Don't matter.
I mean, you can see in the image that the valve has
clear.
increased massively, especially on the mobility of the anterior leaflet.
I prefer the new way.
And also these funny calcium nodules as well.
Well, the funny calcium nodules, I hope they're still there. Yeah, look, the posterior leaflet
is there.
Calcium is there.
The commissure is open better.
Again, the ridges
indeed, the medial commissure is open as well. That I would aim for the lateral one because the medial one is calcified, but the medial commissure is open as well. So,
no sé, bueno, es igual.
The result is very good, I would say.
Have you stored the image of the gradients? Okay.
Well, es que hacerlo instantáneamente.
Another important step of the procedure is how to retrieve the balloon, and Guillermo is going to do it because you need to follow step by step the instructions.
First, the pigtail wire with the stretch tube. First wire.
So we insert the stretching tube a little bit only, just to insert the wire, the 0.25 wire inside the balloon. I think we need to deflate the balloon better.
Mete el plateado. Mete el plateado, si no, no te irá hacia arriba. Mete el plateado. Okay. We need to advance the stretch tube.
It's inflated, the balloon. You are seeing
okay, yes.
Okay.
So, Guillermo, yours.
Sujetable un poquito ahí. Bueno, vamos a esto.
So we need to deflate the balloon better And then the steps are similar than before.
Okay.
The wire is there, up in the left atrium. We're going to advance the silver one towards the golden one, metal with metal.
And now, gold against the key lock.
Metal with plastic, okay?
We retrieve a liter because with the perforation with the left, with this. Okay. No, okay. Yes. Lock is perfect stretching.
Yeah, it's good.
And we retrieve the wire.
A little bit the balloon as well, because you're in the
No, but
okay.
it's okay. It's okay.
Okay, as we told you before, we have prepared a preclosure with ProGlide.
And with the balloon, it's smooth, very smooth, no problem. Yes, I know.
So I think we are almost done. We are going to retrieve the balloon and advance the ProGlide. Please a syringe with saline.
There's a small atrial septal effect left, of course, which is usually small with a left to right shunt, which is the normal and usually closes after a few weeks, I guess.
No, it's better without like for the.
Bueno,
Okay.
muy bien. Voy a volver a...
It's very easy to take.
Sí, bueno.
Yes, no problem. Okay, stretching. Like previous.
So some people use this ProGlide to closure even the veins when there are big bore accesses, and some people do some compression or another tricks. We have very good experience with this approach with mitral clip and big sheaths. Okay.
Any questions, Clara?
No. There aren't any new questions.
You can see, it's closer. I'm going to press a little bit, 30 seconds. But I think if there is no question.
No, if you have questions, my Twitter is.
Any other comments, Silvia, Jesus, just before?
No, the result is very good, to be honest, and well, it's a bit annoying because if you look at the calcium, the case was so. There were some concerns about the medial calcium, but the result is excellent. However, so there's some degree of unexpected results that you cannot predict with the image.
Yes, this kind of cases are quite unpredictable, but I think this case is very educative. It's not a so common procedure, and I think we have spoken about a lot of things regarding this mitral valvuloplasty. So thank you all the team, and see you at 2 p.m. Madrid time for the second live case. Bye-bye.
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 Bye, thanks.